Hello, everyone. Thank you so much for joining us today. I am Daniel Raymond, Director of Policy for the National Viral Hepatitis Roundtable, and we are a co-sponsor of this webinar series with our partners at Hepatitis B Foundation. We'll do introductions and table setting in just a moment, but I wanted to thank everybody for attending today. This webinar is being recorded, and we'll make sure to get the recordings out to everyone who registered. Next slide, please. So we have all the attendees on mute so that we can focus on our panelists. We do have a chat for if anybody wants to say hello, introduce themselves, let us know who's here. That's really helpful for everybody to tailor their remarks. We also do have a Q&A window, which we'll be monitoring, and there will be some time for Q&A and discussion at the end. And so feel free to type your questions in as you think of them, and we'll do our best to keep track of them and make sure that we return to them. But as I said, the sessions will be recorded and we will share the slide presentations. Next slide, please. So I wanted to turn it over to my co-host, Michaela, to introduce herself and Hepatitis B Foundation.
Thanks so much, Daniel. So hi, everyone. It's so great to have you all. My name is Michaela Jackson, and I'm the Program Director of Prevention Policy at the Hepatitis B Foundation. And one of the reasons we're hosting this webinar is because one of the main things that we do is public health education, and immunization is a big part of that. So the Hepatitis B Foundation is the only nonprofit that is solely dedicated to eliminating hepatitis B and finding a cure for hepatitis B in the world. And we do this through a variety of ways, largely awareness, supporting people who are living with hepatitis B, focusing on treatment initiatives, and a lot of research, public health and scientific as well. And with that, I can turn that over to Daniel to talk about his organization.
Thanks, Michaela. I also want to acknowledge your colleague, Catherine's also on the line assisting us. Thank you so much, Catherine. And as for me, as I said, Daniel Raymond with National Viral Hepatitis Roundtable. We're a network of patients, healthcare providers, public health leaders, community organizations, and advocates working to eliminate viral hepatitis as a public health threat in the United States. To get a sense of our work, you can check out our website at www.nvhr.org. And let's move to the next slide. So we're really pleased to have a great panel today to talk about essentially how to talk about the importance of childhood immunization for hepatitis B. We'll start off with a presentation by Dr. Kathleen Schwartz, who's a pediatric liver specialist with Rady Children's Hospital in San Diego and UC San Diego. We'll follow that up with some remarks by John, an advocate with Hep B Foundation's Just Be Storyteller project, to talk about his experience from a personal perspective. And then we've got a couple of colleagues from a great organization, Vaccinate Your Family. Levensna Fantillion and Damaris Lara will be talking about their insights into how to discuss the role and importance and value of immunization in a time where there has been a lot of budding questions or controversies around a lot of our long-held assumptions about immunization. Can we go to the next slide? So some of you may have joined us last week for the first of this two-part webinar, where we were lucky to have Dr. Calvin Pan talking about the basis for what we've had in place for now over 3 decades in terms of a vaccine schedule that includes birth dose immunization for hepatitis B as part of a three-part series. And we also had Dr. Brian McMahon talk about the experience in Alaska in implementing a robust childhood immunization program in response to endemic rates of hepatitis B. Uh, Again, that recording is available, but I just wanted to talk about a few highlights. So World Health Organization, CDC, and American Academy of Pediatrics all recommend hepatitis B vaccination, initial dose within 12 to 24 hours after birth. This was in response to the uh, the concerns coming out of the 70s and 80s that we had significant transmission both from mother to child perinatally, but also during childhood horizontally. And we heard from Dr. McMahon the experience of Alaska, where they had very significant rates among the native and tribal populations of hepatitis B, including acquisition during childhood. And they really moved ambitiously to put in a successful immunization program that really reduced those rates of childhood chronic hepatitis B very dramatically, along with the rates of liver disease consequences. And they've been doing ongoing surveillance for, I think, about 40, over 40 years now of what happens to children who got immunized, and they find that they still have a robust immune response when tested, suggesting ongoing protection from infection. So we do have decent hepatitis B screening rates during pregnancy, but not all pregnancies end up being screened for hepatitis B prior to delivery. Maybe 10% of them uh, don't get screened. So there are opportunities to miss potential for preventing perinatal transmission. We are doing fairly well in terms of birth dose and in terms of completion of the three-dose series during childhood. But as we've seen most recently in the United States with measles, there is dangerous signs of ebbing of the levels of vaccination that would be protective at a community level. Next slide, please. So I think one of the things that is really important to keep in mind is that in the 1980s, before the implementation of universal hepatitis B birth dose immunization, 18,000 children every year acquired hepatitis B under the age of 10 or through the age of 10. So that's nearly 200,000 children who acquired this vaccine preventable disease in the 1980s. What we have seen is that it's estimated that half of these infections were from perinatal or mother-to-child transmission. From a mother with hepatitis B. But the other half were not attributable to mother-to-child transmission, suggesting horizontal transmission, that it's very easy to acquire hepatitis B, relatively easy, through cuts or scrapes if if there is hepatitis B within blood that's even in small amounts in droplets on surfaces, that the virus tends to be fairly persistent and seen in higher concentrations than similar viruses like HIV. And so that kind of twofold need to prevent acquisition of hepatitis B, both from mother during delivery who is chronically infected or through horizontal transmission, provide the backbone of the birth dose recommendation. And the other key concept is that while those of us who are familiar with hepatitis B recognize that in adulthood, acquisition of acute hepatitis B, a new infection, does not always lead to chronic hepatitis B. For most people who are not immunocompromised, it won't. The story is different for children, that a significant proportion of children who acquire hepatitis B during infancy or early childhood will develop chronic hepatitis B and be at risk for significant liver disease consequences. We think about hepatitis B vaccination, therefore, as liver cancer prevention. And we also recognize that our best estimates are that something like 25 to 35% of hepatitis B people living with chronic hepatitis B, only a fraction of that overall population is being diagnosed. We still have the majority of people with chronic hepatitis B unaware of it, which means that immunization is our best line of defense, even as we're working to increase those diagnosis rates. So that's a rough recap of some of the points that Dr. Pan and Dr. McMahon covered in the first part of this two-part series. We want to use that as a base to kind of think about in this era where a lot of people are expressing uncertainty, hesitation around immunization, broadly speaking, that is sometimes uh, directed towards hepatitis B childhood immunization. How should we be thinking and talking about the importance of shoring up the case and rationale for widespread hepatitis B childhood immunization, including the birth dose? And so for that, I'd love to turn it over to Dr. Schwartz to walk us through her insights into this question. Dr. Schwartz, over to you.
Thank you so much. And I thank both the Hepatitis B Foundation and the National Viral Hepatitis Roundtable for this wonderful invitation to talk to you all. Now, last week, you heard two eminent researchers, Dr. McMahon and Dr. Pan, talk about their global experience. And my talk is going to be much more of a boots on the ground speech because I'm a pediatric liver specialist and I have cared for probably 200 or so children with hepatitis B. So this is a much more personal experience. Michaela? Next slide, please. So I will kind of skip over my published experiences with hepatitis B, except for a couple of instances. And I will also confess that I worked in the lab for a number of years with woodchuck hepatitis virus, which you probably know is the best animal model for hepatitis B, trying to understand how woodchuck hepatitis virus and hepatitis B cause liver cancer. Now, one of these experiences led me to Taipei, Taiwan, and there I attended a World Congress of Pediatric Gastroenterology. The host was Mei Wei Chang, and Mei Wei was president of our International Foundation, which is most of the pediatricians in the world who have focused on either GI, the liver, or nutrition, or all three. So Mei Wei is a global expert in hepatitis B. She demonstrated in Taiwan that with universal hepatitis B vaccine, the incidence of hepatocellular carcinoma in Taiwanese children fell dramatically. And it was interesting because I was at the meeting where she presented this data, which was published in the New England Journal. And Jay Hoofnagel, the director of the NIH Liver Center, said, wouldn't Dr. Jonas Salk be proud? Because even he could not imagine that a vaccine could prevent cancer. And Mei Wei just demonstrated it. So Mei Wei and I have very strong interests in hepatitis B in children. And we said, and this was 2012, we said, we have a safe and effective vaccine. At least in some parts of the world, it's supposedly given to all newborns. Why is the number of cases of hepatitis B growing in the world. So we embarked, she had been president of this federation, I became the president, and we embarked on a global study to try to understand what the impediments were. And I'll show you in a slide or two that we found several impediments to the prevention of maternal fetal transmission. But the main one was that around the world, there are so many babies born outside of medical facilities that they don't get the vaccine. So this is published information. So then I will share the issues that I have faced in caring for these couple hundred children with hepatitis B and their families, because as you probably know, in childhood, for the most part, hepatitis B is a clinically silent disease. It does progress to cirrhosis and liver cancer in adulthood, but nonetheless, there are some significant issues that these children and their families face. Then I'll share some struggles of individual patients, and finally, some solutions. Next, please. So, as I said, this is really a boots on the ground talk, because I'm a clinician and I know up close and personal the struggles that these families and the kids face. Next. So this is the paper that I mentioned that we wrote in, I think we started the study, we started talking about the study in 2012, finally published this in 2019, but this is what we found, this staggering number, how many infants in the world are born outside a medical facility. So this is the percent of countries for which newborns can't get vaccine because they're born outside the hospital. So in Africa, it's very common, and Asia Pacific, it used to be more common, but less so. Europe is only about 10%, Latin America, 50%. Fortunately, knock on wood, we do have available vaccine for all newborns in North America. And the total, about half of the countries in the world lack hepatitis B vaccine for the outborn infants. So this was Maywee's work, because we wanted to end this publication with a happy note. Hepatitis B surface antigen rates before and after universal hepatitis B vaccination in children. So really dramatic improvement that the vaccine has given us. Next. So as I said, the children that I have cared for, both in San Diego, where I've been since 2018, and Johns Hopkins in Baltimore, where I was on the faculty for 34 years. All these kids with hepatitis B and their families face stigma and fear. And I think the fears are threefold. One is the fear of the disease progression, because as you probably know, hepatitis B is a highly carcinogenic virus and can progress, particularly when acquired by young children, can progress during the life to chronic liver disease and liver cancer. And of course, the worry about financial loss and fear of infecting others. So these are the primary impacts. And I used to kind of joke that my subspecialty at Johns Hopkins in Baltimore was made up of Washington lawyers, married to Washington lawyers who couldn't have a baby went to China to adopt a pretty little girl. And sometimes when they adopted the child, they were told that she had hepatitis B, but often that information was not shared with the adoptive family. So then they brought the child back to America and then only then learned about the hepatitis B status. But I've had many families tell me that they lost babysitters, they had to move because they were ostracized by neighbors. I mean, there's there are a lot of primary impacts, and this is secondary impacts, stigma and discrimination from the community, sometimes even healthcare providers and institutions, particularly the military. And finally, tertiary impacts. The child worries about being a pariah and is lonely, withdraws from society. Those who acquired hepatitis B by their own activities feel guilty, self-stigma. So this stigma and fear, all children with hepatitis B and their families suffer in one way or another. Next. So I joined the Johns Hopkins pediatric faculty in 1987. And one of the most dramatic experiences I had involved this 15-year-old girl. So Johns Hopkins was one of the first centers in the country to develop pediatric liver transplantation. And I was the medical director, and I worked very closely with the surgeons. And in December, mid-December, we were called to the emergency room. There was a very ill teenager who had fever and jaundice. And it turned out that this girl had acquired hepatitis B, a sexual encounter, and she went into fulminant liver failure. So her liver enzymes started getting higher, and she became jaundiced. She couldn't clot her blood. And we finally decided we had to do an emergency liver transplant. I remember it very well because it was Christmas Eve. And so she did well initially. And then, as you see, the survival of liver transplant is not 100%. And I was asked to give a talk on hepatitis B maybe 7 or 10 years after we had been taking care of this girl. And I just looked up her record, and she died of complications of over immunosuppression. It was also the early days of liver transplantation. And that just made me so sad because I thought, this is a vaccine preventable disease. And hepatitis B vaccine is free. But this was a inner city teenager who had never received the vaccine. And so I said, I got to do something about this. Next. So I embarked on a study in which we immunized and vaccinated homeless teenagers. And it is so important to get those vaccinations done to all those who deserve it. Now, these are 3 more cases that also were tragic. And of course, you remember the tragedies especially. So hepatitis B and also hepatitis C, of course, cause chronic hepatitis, cirrhosis, and then can not always, but can progress to liver cancer. Now, liver cancer from hepatitis B usually occurs in adulthood, but I had several experiences with children with hepatitis B, and I know Brian McMahon in Alaska had a number of cases with children with hepatitis B who had liver cancer, probably due to the unusual genotype of hepatitis B that he encountered. So the first child I saw with hepatitis B liver cancer also had hepatitis C, and he was a child whose parents and the child had been in a terrible automobile accident when he was young. And I think the blood was not screened for hepatitis B or C then. I think this was before 1989 when the hepatitis C virus was identified. And so he required transfusion, and the blood wasn't screened for B or C. And so he acquired both of these viruses with transfusion. And then at a very young age, developed liver cancer, and from which he died. Another memorable and tragic case was an African 15-year-old girl with a surgeon father. And the father brought her to me. There was just one clinic visit, but she was complaining of a lot of abdominal pain. As I said, hepatitis B usually is symptomatic in childhood. And I did an ultrasound of her liver right away, and she had a big mass. She had hepatitis B liver cancer. And it was my first year on the faculty. I was a young assistant professor, and the father took her back to Africa, left his job in America, took her, no trace. And as you can tell from my talk, that child is still on my conscience, because now that I'm a crabby old lady and I'm much more aggressive about chasing people down, I probably would do a much better job of trying to get that child back in care. And then another series of hepatitis B liver cancer that left a big mark on me actually were adults with a tumor. Why do I put, I'm a pediatrician, why did I put that on this slide? Well, when I was new at Johns Hopkins in the late 80s, I had an NIH grant to carry out my ideas on how hepatitis B caused liver cancer. And so part of that grant, I went into the operating room, and where there was someone who was getting operated on either for hepatitis B liver cancer or other kinds of tumors. And the surgeons shared some of the tissue with me. I took the tissue to the pathologist, and once the pathologist had marked everything he or she needed to mark, they gave me a sample that I could study. And the reason that it struck me as so sad is that I saw several military vets from World War II, I think from the Korean War as well. And they had acquired hepatitis B from our military. So it turned out that mass immunization programs, the military were using the same needle. So I thought, what a tragedy that these people served our country and yet ended up with a contaminated syringe which carried hepatitis B to them. We don't do that anymore, but let's hope that's in the past. Next. So another child that I started taking care of in Baltimore, and I currently take care of in San Diego, military family. This child was an international adoptee, and he happens to be a fabulous soccer player. So he was in one of our early clinical trials of antiviral agents in Baltimore, and he has responded very well to the treatment for hepatitis B. And since it's a military family, the family was moved from Baltimore to San Diego, so I still take care of him. So now he's grown up. He's still a very, very talented athlete. He's a very talented soccer player, and he's applying to colleges. So he has undetectable virus because he's been taking the drug that I prescribed for so many years. And yet his family were very worried about whether or not they should disclose his hepatitis B status to the colleges and universities to which he was applying. And he's such a good soccer player that he was offered several different scholarships, soccer scholarships. And so I actually finally put the family in touch with Sherry Cohen of the Hepatitis B Foundation to try to explain what their rights were in terms of disclosure or not. And very intelligent family. And I think although Sherry assured them that they did not have to disclose the hepatitis B status, I think they finally just decided it was just too risky. And so he decided not to accept the scholarship. And now he wants to go in the military after school, after he finishes college. And that of course, is also going to be a problem because the military prohibits patients who are hepatitis B surface antigen positive. So again, I put them in touch with Sherry, but just one more example of why I'm so passionate about taking care of kids with this condition and why I'm so glad that you all are so focused on birth immunization. Next. So what are the solutions? Well, better public policies regarding vaccines, including the birth dose, better outreach with vaccines to the vulnerable, including the homeless and incarcerated, because after my experience with that youngster who needed an emergency liver transplant from hepatitis B on Christmas Eve, I did get a grant which allowed us to go out to historic East Baltimore, to the homeless shelters, and we found very few of the children in there had ever received vaccines, even though they're free. And it took a major outreach, but we were able to get most of them covered with vaccines. And then, of course, in addition to the birth dose, and HBIG for newborns born to hepatitis B positive women, treating pregnant women in the third trimester has been shown to markedly decrease transmission. And then improved screening in family health centers, particularly using creative use of the electronic record. Educating healthcare providers regarding treatment options, and also education about the ADA policies, which protect families from the need to disclose. Next. So vaccinate the vulnerable, including the children. We were very successful in our outreach to the homeless shelters, but it took a big effort. Next. And hepatitis B in pregnancy, as we know, there's both the birth dose, hepatitis B immune globulin, and then treating women with high viremia in the third trimester. Next. This was our experience in in 43 family health centers in San Diego. So, and we started this project with linking a reminder to screen for hepatitis B, linking that reminder to with the country of origin. So any patient in the family health center, and there were a couple 100,000, any patient who came from an area of high prevalence, so the country of origin that had a prevalence of hepatitis B of 2% or greater. And so we started this, and it turned out to be, this project turned out to be at the beginning of COVID and lasted for several years, reminding providers to screen for hepatitis B based on country of origin. And as you can see in A, the persons tested is on the left side of the A chart, but if the patients came from a country of origin of hepatitis B prevalence of around 2%, we had 8% of those who were screened were hepatitis B positive. And if the patients came from a country of origin of high prevalence, 8% or more on the right, up to 20% were detected. So we want to do a lot more of this, linking the country of origin, or some people think that the CDC is not going to allow the country of origin as part of the personal identification. So then the reminder would be based on the language spoken, because that is publicly available information. Next. Next. So this is the end. I just want to thank the Hepatitis B Foundation and the National Viral Hepatitis Roundtable for this opportunity to share my boots on the ground experiences.
Thank you so much, Dr. Schwartz. That was very illuminating. We'll go now from a provider perspective to a patient perspective. We're going to hear from John, who is a Just Be storyteller. And I think before John speaks, we're going to play a little bit of John's story on video, and we'll make sure everybody has the link. The full video is well worth watching.
I'm cycling in the middle of the afternoon. It's June in rural Georgia. Waves of heat rise from the tarry asphalt of the highway as semis roar past, my bike and I blowing like a leaf in the wind. The air is so thick you almost have to chew it before taking a breath. Salt from sweat stings my eyes, and I'm trying to distract myself from the hundreds of miles left to ride. I'm thinking about my 18th birthday, only a couple weeks away, and how so much can change in a short amount of time. Like when my mom took me to see the doctor a couple of years earlier. I was 16 and having stomach pains, so we waited what felt like an eternity in the small exam room, the high hum of the fluorescent lights buzzing overhead. Finally, the door swung open and the physician assistant entered.
We've done some blood work, Mr. Ellis. There may be some mistake, but you've tested positive for hepatitis B.
I didn't even know what that meant, but my mom's reaction said it all. When I went back for more tests, My mom stayed in the waiting room so I wouldn't see her cry. Just like that, my life changed.
John, thank you so much for joining us. And also, Catherine, thank you for dropping the link to the full video and chat. Uh, John, I'll turn it over to you for your remarks.
Yeah, certainly. First off, thank you for allowing me to participate in this. I always learn a lot myself, even as someone who has hepatitis B. At the end of the day, I'm just a 34-year-old man, and I know enough to take care of myself. But the slides that you shared earlier, Daniel, I mean, that really is kind of representative of my story. I was born in 1990, prior to birth dose sort of being common practice. And from the time that I was born to roughly middle school, when I went for booster shots, that's when I contracted hepatitis B. I think obviously we live in interesting times where the debate around vaccination is, being had. And certainly I think in my case, had I received the birth dose vaccination, I wouldn't have been diagnosed with hepatitis B at the age of 16. So certainly as a patient, I absolutely would advocate for, hepatitis B vaccination at birth. And it's kind of emotional to hear some of these stories about people who, didn't have access to vaccination or just weren't aware of vaccination. I applaud the work that you all do. I appreciate the work that you do, and I think obviously there's still work to be done. So thank you.
Thank you, John. And I think it's really part of the intent here for this webinar when Mikhail and I were planning it was that we can talk about the evidence, we can talk about the science, but people who have direct personal experience as patients, as caregivers, as healthcare providers are going to be an important part of this conversation going forward.
Certainly.
And we'll have some time for discussion, but I wanted to give a few minutes over to our colleagues from Vaccinate Your Family, Lavesna Fontilian and Damaris Lara, because they've been doing a lot of work, not just around hepatitis B, but more broadly around immunization, and really seen up front some of the challenges, but also I think meaningful opportunities to come at these debates with strong values-based messaging. So Damaris Lavesna, I'm going to turn it over to you.
Thank you so much, Danny, and thank you so much, John, for sharing your story. Yes, I'm Damaris Lara. I'm the communications lead at Vaccinate Your Family, and with a particular focus in Spanish-speaking communities as well. I'll take it over to my colleague, Love, for her to introduce herself.
Yes, good afternoon, everyone. I am Lavesna Fontilian, and I serve as the Health Promotion Coordinator at Vaccinate Your Family.
Awesome. So today we're going to be talking about messaging and addressing misinformation. I think now more than ever, we really need to have our messaging right, as well as coming from a situation of empath and being empathetic for people and parents, particularly who have doubts about vaccination. Next slide, please. So at VYF, our main mission is to protect people of all ages from vaccine preventable diseases. We also really combat misinformation, access to vaccines, and just ensuring that everyone is protected for a healthier future. Next slide, please.
Yes, so specifically today, Damaris and I are going to be speaking about messaging and addressing misinformation. So unfortunately, misinformation about vaccines has been around for a very long time, and I think we all understand how it can create real barriers in regards to vaccine confidence. And that's why it's very essential to address it proactively, especially at the community level. So, what can public health workers do to address vaccine misinformation? First, I think it's important to lead with empathy. It's important to acknowledge concerns and to build trust. It is very normal to have questions and concerns about the safety of any product, whether it's food or medicine, and that includes vaccines as well. Second, I'm going to talk a little bit about the truth sandwich, which is from our viral myth-busting campaign. We highlighted this strategy as a means to basically combat misinformation during the respiratory season, but it's also very useful to engage your community to tackle vaccine misinformation. So the breakdown is basically this: to number one, start with the fact. Number two, warn about the myth. Three, explain how the myth misleads. And four, reinforce the fact. So the third thing that public health workers can do to address misinformation is to, again, emphasize vaccine safety. It's very important to highlight that there are rigorous testing and monitoring processes for vaccines to ensure that they are safe for you and your family. Fourth, engage with trusted messengers. And what I mean by this is to leverage community leaders and healthcare providers at the local level. Fifth, proactively correct misinformation. Use evidence-based resources to debunk myths. So these are approaches that public health workers can use to build vaccine confidence and combat misinformation as well. Next slide, please. Next, are there any key messages that public health workers should be using to discuss vaccines with the public? So first and foremost, it's important to note that parents do choose to vaccinate their children according to the recommended schedule. About 9 in 10 parents choose to do so. Again, it's important to highlight that vaccines go through a very rigorous monitoring process, more than any other medicines, and much more than foods, supplements, or any other products that we might use or consume all the time. Lastly, it's very important to note that choosing not to vaccinate is not exactly a risk-free option. It leaves your family vulnerable to serious deadly diseases and other complications as well. So on this slide, I do want to highlight two resources to keep you informed on vaccines. The first one is our Insights and Resources page. This page shares the latest updates on immunization trends, disease outbreaks, and new vaccine recommendations. And it's really just a great way to stay current on what's happening in the field. Another great tool is VYF University, which offers free online courses such as how to talk with people about vaccines. And we have new courses for providers coming soon as well. So again, these are excellent free resources to help you stay informed and support your community. And we'll be sure to share these resources after the call. Next slide, please. So for resources specifically for hepatitis B, the Children's Hospital of Philadelphia has a very informative infographic, and Vaccinate Your Family has a children and teen ebook, which offers information about hepatitis B as well. These resources can be used to discuss vaccines with the public and with your local community. Damaris?
Yes, next slide, please. So now we get into the question, right, of how can we speak about childhood vaccines broadly with parents who aren't sure if they want to vaccinate their children? So, of course, for this audience, we know that every single vaccine is backed by science. However, What we do know is that oftentimes science is not enough when it comes to explaining to parents why it is so helpful to vaccinate your kids to secure their future. So the first recommendation that we have is to soften the science. Yes, we can provide the science-backed information, but we first have to validate that parent's feelings. At the end of the day, we all know that parents want to protect their children, and we really need to make sure that we reference that concern and that we understand where those feelings are. So just going back to the basics, right, of being empathetic for those concerns, even when we come from this medical public health field. The second recommendation, and a very important one, is meet them where they are. Right now, more than ever during this time of misinformation, we really want to engage with community health workers. Community health workers are on the ground doing the work for us and really being able to provide that culturally relevant messaging as well, whether that's meeting them at a religious event, at a church, at a community event, and really honing in to those partnerships with community leaders is going to provide and create that trust that we need in vaccines during this era as well. So very important to obviously have the science-backed information, but have those messengers that can provide that science-backed information in our communities. And then as well, and very important, personal stories like the one that Don just shared about his experience, as well as parents who are deciding to vaccinate their children and making sure that we amplify those stories to make it relatable and to create a more humane approach to vaccines is a really, really great option for us during this age as well. Next slide, please. Cool, now we're going to our questions, and I'll leave it to Michaela and Daniel.
Thank you, Damaris and Lavesna. I'll pass it to Michaela. We have a few minutes left, and I know that Dr. Schwartz has clinic starting at the top of the hour. But if you have questions, feel free to type them in chat or use the question and answer box in Zoom. Michaela?
Perfect. Thank you so much. So as Sana said, please feel free to send in your questions. But I think I'll start with one for everybody. So with hepatitis B, as Dr. Schwartz mentioned, it really doesn't have any symptoms for the most part until it progresses into a later stage, which sometimes makes it a bit difficult to talk about with people if it's something that they can't see. Sometimes with other vaccines, you can kind of see what happens with the flu, very visible. With the children with measles, you can see that. So are there any suggestions from you all of how you might talk with a parent who really thinks their child might not be at risk for this virus and they don't want to get them vaccinated because they simply don't see it within their communities, or they just don't see it spoken about and with anybody? And I can perhaps turn it over to Dr. Schwartz first.
Oh, I get the easy questions. Well, I loved your approach, Damaris, about being empathetic, because I do think that often a refusal to vaccinate, which to us healthcare providers seems very irrational, that it is often fear-based. But of course, why am I and other physicians so eager to diagnose and treat children? We're afraid too. So trying to get everybody on the same page. And I will say that the internet is useful with graphic designers, such as the graphs that I used in my presentation showing a normal liver and how it can progress to cancer. I think those, just a few simple images can go a long way. So both the empathy and the communication.
And Maybe, John, as somebody who has personal experience living with hepatitis B, is there anything that you might say to a parent who is considering not vaccinating their child?
Yeah, I guess I'm getting the easy questions now. Um, personally, I believe to each their own. Who am I to tell someone, what they feel like is appropriate for their family, for their children. But I know, like I can remember the experience my mom had, who was a nurse and has been a nurse for 40 years. As someone who was in the medical field, I think she was more terrified for me than even I was. And I think to think back on just how emotional that time was, how scary it was for her and for me. You know, had I been vaccinated at birth, we could have skipped all that, right? I think back to the slides that were shared regarding about the fears that come with being diagnosed. I still to this day think about what happens if my chronic hepatitis B gets worse. I've been very fortunate, and in part being diagnosed when I was. I think the treatments that I've had over the years have put a lot of that at bay. But yeah, long-winded answer to say, the fear of the unknown, of being vaccinated, or the perceived fear of the unknown, versus the security and the trust in being vaccinated, I think far outweigh those fears.
Thank you. And I think it just kind of goes and ties into what we were all saying about having a personal story, especially for something that's not as visible, is really important to getting messages across for people because, as Vaccinate Your Family mentioned, a lot of parents will go ahead and vaccinate, but sometimes it's as simple as being on the fence because they have a few questions and they might not understand what the potential consequences of not vaccinating are. And then we have a really great question in the chat. Often the pushback that we get from parents regarding this vaccine's hepatitis B is that the idea that it's only spread through sex, we definitely hear that a lot. People perceive that their young children don't need it for that reason. Do you have any talking points for discussing risk for spreading through other means that we could potentially share with families? I can start with that and say that the Hepatitis B Foundation does have a lot of resources as well as the Children's Hospital of Philadelphia that we're happy to put together and share with you all. And then Vaccinate Your Family, you guys might have some thoughts as well.
Yeah, so our children's and teen ebooks have some messaging around that when we're talking about Hep B, as well as our frequently asked questions on our website as well. So we can definitely send out those links after this webinar so that folks can have the right and appropriate messaging as well.
I can also share something that I learned from Adrian D. Bichelli about horizontal transmission. Dr. D. Bichelli is from St. Louis. He's originally from South Africa, very knowledgeable about hepatitis B. And he shared with me that particularly in Africa, it's quite common to have horizontal transmission, meaning person to person, not sexual or not transfusion acquired. I said, well, how does that happen, Adrian? He said, missionaries. I said, missionaries? How do missionaries spread hepatitis B? And he said, they give wooden pencils, but they don't give pencil sharpeners. So the children who attend school in these brick schoolhouses take their wooden pencil, they go to the wall and sharpen the pencil. And if somebody, some other child who had hepatitis B sharpened his or her pencil before, then they left hepatitis B contaminated blood in the hole that the child uses to sharpen the pencil. So that is apparently a known. There are other causes of horizontal transmission, of course, but I thought, oh my goodness, what we don't know. So many ways. And I do have to thank you all for allowing me to speak. And now I have to go take care of my pediatric liver clinic. Thank you. Bye-bye.
Absolutely. Thank you, Dr. Schwartz. And so I know there's a couple of questions that we didn't get to in the chat, but as we are at top of the hour, I will go ahead and we will be certainly to share resources in the email, as well as the presentation slides, and answer that question as well. But thank you all for showing up today and for the part one of our webinar. These, as we mentioned before, will be recorded or are recorded and will be available shortly. I'm leaving Daniel's email and my email on the screen. So if anybody has any questions about anything at all, please feel free to reach out to us. But we appreciate your time. Thank you to all our presenters for both webinars, and I hope everybody has a fantastic rest of their day.
Thank you, everyone.
Thank you.
Thank you.
Thank you.
Thank you.